Hi there, and welcome to this month's case study. Today we're going to be reviewing a case on heavy menstrual bleeding. Just real quick, here's our disclaimer, and just a reminder that this is for educational and informational purposes only. So here's me. I'm Dr. Rebecca Clemson. I'm a naturopathic doctor and clinical consultant here at Precision Analytical. And here are our learning objectives for today. We're going to do a quick review of heavy menstrual bleeding, causes and assessment, review Dutch sex hormone case study, and then a quick review of some treatment considerations based on our Dutch sex hormone results. So heavy menstrual bleeding, it really is one of the most common gynecological complaints of premenopausal women. It affects really anywhere from 10 to 35% of women of reproductive age, and it's associated with lower quality of life, high healthcare expenses, and loss of productivity. So how do we define heavy menstrual bleeding? It's considered a total blood loss of more than 80 milliliters per menstrual cycle, or bleeding that lasts longer than 7 to 9 days, depending on age. That can be really hard to quantify objectively, so we do have a subjective definition too, and that's defined as a volume that interferes with the patient's physical, social, emotional, and/or material quality of life. So who's most at risk to have heavy menstrual bleeding? Really, there's two categories of a patient population that we tend to see heavier bleeding in, and they're really the adolescents and perimenopausal women. So for adolescents, they're more likely to have anovulatory cycles and heavy periods during the several years surrounding puberty. And really, part of that is the estrogen receptors are just more sensitive to being exposed to all the hormones all of a sudden. And then with perimenopause, we start to see more hormonal fluctuations, progesterone starts to drop. Estrogen can go on a bit of a roller coaster ride, and we will start to see more anovulatory cycles too. So what are the causes? There are a lot to consider. One way to kind of simplify thinking about them is to put them into one of three categories. We have hormonal, and those really center around things that are going to affect progesterone production, so lower progesterone and possibly increasing estrogen. So remember, estrogen is building that uterine lining and progesterone stabilizes it. So when there's an imbalance there, that could lead to heavier periods. There's also a mechanical and structural category and clotting abnormalities. So here are the three categories and the different causes listed under each category. So you can see with hormonal, we have hypothyroidism, anovulation, luteal phase defect, ovarian cysts, exogenous hormones, so taking exogenous hormones, stress and inflammation, obesity, xenoestrogenic exposures, and then high prolactin levels. Mechanical and structural things more like uterine fibroids, uterine polyps, adenomyosis. Sometimes we'll see it with endometriosis. Copper IUD, a lot of women experience heavy menstrual bleeding at first, and that can take some time to resolve. Cancer, ectopic pregnancy, miscarriage, pelvic infection. And then our clotting abnormalities, we have coagulopathies. The big one is von Willebrand disease. This one actually can affect about 20% of women who have heavy menstrual bleeding. So it's definitely something to keep in mind and really get a good family history and just a history. If someone's been having heavy bleeding their entire life, there's a good chance they might have this disorder. So it's definitely something to look into. There's also vitamin K deficiency. Anticoagulant medications could affect clotting like warfarin, dysproteinemias, and then severe hepatic disease. A couple other things to consider, some nutrient deficiencies. Vitamin A, I thought this was interesting. So I wasn't aware of this, but vitamin A is associated, like vitamin A deficiency is associated with heavy menstrual bleeding. And when vitamin A was repleted, for many women, the bleeding got a lot lighter and normalized. Also, for iron, we often think about iron deficiency as a symptom of heavy menstrual bleeding, but also, it can also contribute to heavy menstrual bleeding. So it is both a symptom and a cause. So that's something to consider. And often with women who do have iron deficiency, when we replete the iron, the bleeding will normalize as well. And one note I wanted to make about inflammation that I thought was really interesting, in the research, they found that there was altered arachidonic acid utilization in the endometrial tissue in heavy menstrual bleeding, and that caused an increase in series 2 prostaglandin production, which contributed to excessive bleeding. So basically, the endometrial tissue of women who experience heavy menstrual bleeding increases utilization of arachidonic acid, which is an omega-6 fatty acid that's pretty pro-inflammatory, and that will increase these inflammatory prostaglandins that cause heavier bleeding. So that's something that we can consider as like something that we can address dietarily. We can lower the arachidonic acid exposure in our diets, and that's really coming from animal products like dairy products and meat. So that's, again, good to know because it's something that can be addressed. So how do we quantify the blood loss? This can be kind of difficult. Again, we're looking for more than 80 milliliters during a cycle, and that equates to approximately 3 completely full menstrual cups. You really need to check in on menstrual cup size, though, because sizes can vary, and there are smaller ones. So check in and see, what size they're using. And maybe it would be, with a smaller one, equate to more like 4 full menstrual cups. It also is approximately 16 fully soaked regular tampons or 8 fully soaked super tampons during the entire period. So you can do your best, ask patients how many period products they're using. Oftentimes, though, people are not waiting until they're completely soaked to change them, but you can still kind of do your best to get an idea. And really, if someone's having to change their pad or tampon on an hourly basis, that is definitely concerning. So further assessment and treatment goals, we need to run some labs to check in on all those causes that we talked about a few slides ago. So typically we're looking at a thyroid panel, CBC, iron studies, and ferritin, comprehensive metabolic panel, pregnancy test, possibly STI testing if that's, part of the patient's history, and then hormone testing really during the luteal phase so we can assess estrogen and progesterone levels. For physical exam and imaging, we'd like to do a pelvic exam and PEP, endometrial biopsy for obese patients, or if there's a high risk for endometrial cancer, and then pelvic ultrasound so we can look and see if there's fibroids or polyps. And then our treatment goals really are, we want to control the bleeding, we want to prevent and treat anemia, and then we want to restore normal menstruation. All right, so let's move on to our Dutch sex hormones case study. So today we're just going to be focusing on the sex hormones report. And here's our patient. So here's Emily. She's a 20-year-old female. Her chief concern is heavy and long periods. She has previous low progesterone on testing and is wondering if it's still low. And then she also has concerns about acne and mild fatigue and anxiety. Her menstrual cycles are regular and 31 to 32 days in length. She reports being about 20 or more pounds overweight, and has difficulty with weight loss. She's not taking any medications. She's currently supplementing with glutathione. And she did previously use topical progesterone, but discontinued 2 months ago. So that's not going to have any effect on Dutch test results. So let's see her results. So here's our main sex hormone page for the sex hormone results. And what we'll do is kind of go section by section. So in the upper right-hand corner, we have our progesterone levels. So you can see that the progesterone here is falling into that luteal range. And remember, the luteal range is that area between the two stars. So good news is she is making her own progesterone, so we can tell her that. And it looks like she ovulated because she's falling into that luteal range, but she is in the lower end of that luteal range. It could be better. It's definitely suboptimal. Those two metabolites we're measuring, the alpha pregnenolone and the beta, are below, and the alpha is, much more nicely in the range. Beta is a little bit below that luteal range, but together we do a weighted average to estimate, progesterone levels, and she is there, so that's good. All right, so what are common causes for low progesterone? A lot of these we saw on the previous list that could be causes to think about for, you know, heavy menstrual bleeding as well. So stress, inflammation, hypothyroidism, elevated prolactin, PCOS, undereating and or overexercising, poor follicular development and poor corpus luteal production of progesterone. And then, collection timing. This is a big one to think about. Always double check with your patients. When did your period come after testing? Did we really catch that mid luteal phase and the peak levels, or did we collect a little too early or too late? Because that could really affect the progesterone levels as well. All right, so let's look at her estrogen. So estradiol in the middle here, that's our main estrogen, most potent estrogen, and that one's falling right at the top of the normal luteal range. So she's high normal there. And it's nice to compare where the estradiol is falling in its range compared to where the progesterone is falling in its range. And ideally, we want to see the two balance, so both pointing in similar directions in their ranges, or the progesterone pointing maybe a little bit higher even. So you can see she's in balance there. Her progesterone, again, is low normal, estradiol is high normal, so more of like an estrogen dominant picture. And that could be definitely a contributing factor to the heavier periods. We also see that the E3 is elevated, much weaker estrogen, and it is actually a metabolite of estradiol down this 3A4 pathway, but interesting that it's very elevated. And then the estrone, which is another weaker estrogen, is actually a little bit low, but our main estrogen is high normal. So important to keep that in mind. So let's look further at her metabolites. And the big thing you're going to see first is that she's really utilizing this blue 3A4 pathway quite a bit. Her 16-OHE1 metabolite is elevated, it's above range. And then it's a little bit easier to see over to the left-hand side of the screen, the estrogen metabolite ratios. You can see she's quite high with that one, 66.6. And we expect that one to really be 13 to 30%. So really high, predominantly using that pathway for estrogen metabolism. When both the estriol and the 16-OHE1 are high, they're both utilizing that same 3A4 pathway. And when they're both elevated, it's really indicating an increased activity down that pathway. Her 4OH level is actually normal. So that's the more unstable metabolite that we don't want to make much of. It's down that red 1B1 pathway. But her ratio is a little bit elevated. Just a tad. It's not super high, but it is a little bit higher than we like to see. And then the green pathway, our more protective pathway, she's really quite low with that metabolite. So really, we'd kind of like to see more of an inverse here, where she's green on the pie chart should be blue, and where she's blue, we'd like to see her green. So really kind of flipping that. Um, but as you can see, for all of the estrogen metabolite ratios, they're actually all outside of the expected ranges. So what does elevated 16-OHA1 mean? Well, it's a more proliferative estrogen metabolite and has a lot of activity at estrogen receptors. So it can really add to an estrogenic load and can increase estrogen excess related symptoms like having menstrual bleeding. It's going to just keep building that uterine lining, and we don't have the progesterone there to really counterbalance that. So really could be a big contributing factor to the fact that she's having heavy periods. So we do want to address the increased CYP3A4 activity, but we want to also keep in mind that this pathway is important for detoxification of many pharmaceuticals, toxins, and waste products. So we want to try our best to maybe work on decreasing activity, but we don't want to completely block it because we need to be able to detox, medications and other toxins. And another thing that we can, work on is phase 2 detoxification, which for 16-OHE1 and E3 is actually sulfation and glucuronidation. And supporting those pathways can really be helpful when these two metabolites are elevated. So here I've included our steroid pathways chart. I definitely encourage everyone to download the steroid pathways chart. It's really kind of awesome to have as a PDF because you can really zoom in on particular sections like I have here. So here we have our estrogen metabolism section, and you can look at each pathway and see, ways that we can maybe increase utilization of a pathway or decrease utilization. So for instance, with the 3A4 pathway, which we know is upregulated for this patient, what are things that could increase activity? Pesticides, caffeine, smoking, polyaromatic hydrocarbons, alcohol intake, and obesity. So these are all things we might consider addressing to help, decrease utilization of this enzyme. And then ways that we might slow activity here, supplementally, resveratrol and rosemary can be helpful. Grapefruit is pretty strong at blocking this enzyme, so you want to be careful with that one. And then we also have medications listed here that can influence the 3A4 activity, so it's useful to check in there as well. Here we can look at that 1B1 pathway that we saw her ratio is a little bit high. Inflammation can increase that pathway, smoking, those polyaromatic hydrocarbons again, and those are really coming from pollution. So I have a little box over to the right you can check out. Where are those coming from? Pollution, high temperature cooking, basically eating charred food and smoked foods. So those are things that we can work on. And then how can we, inhibit this pathway, slow it down? Flavonoids and resveratrol can be helpful. And then the 1A1 pathway, that's that green pathway that we really want to utilize more, and she's really not utilizing it much at all. Things that slow down that pathway, high sugar diet, alcohol consumption again. So those are things we can work on. And we can support this pathway with cruciferous vegetables, maybe something like dim, fish oil, rosemary, ground flaxseed could be helpful. So these steroid pathway charts can really give you some guidance on like what might we do with like knowing which pathways they're using and if we want to try to optimize estrogen metabolism. Quick look at phase 2 methylation. It's at the bottom of the page here. So ideally, we want to see at least half of this 2-OHE1 getting methylated to make 2-methoxy-E1. And she's right there, so that looks good. Her methylation activity is normal. That's why she's right in the middle of that fan gauge. But both the 2-OHE1 and 2-methoxy, they're pretty low values, so it would definitely be helpful to check in maybe in a few months, check in and see how the phase 1 metabolites are doing and make sure that she's still methylating well with hopefully more metabolites coming down that 1A1 pathway. And a real quick look at her androgens. I pulled this table from page 1 of the sex hormone report. So you can see overall, her androgens are low normal for her age. Remember, she's 20. So I did highlight her age ranges here for each of the metabolites. So she's kind of low normal for most of them, but she does have a strong 5-alpha reductase preference. So, that might indicate that there's some inflammation going on and or insulin resistance, because those can both push that pathway. So on the Dutch test, we do have different indicators for inflammation. We have much, you know, there's a lot more metabolites that might indicate inflammation on our Dutch Complete and Dutch Plus tests. I just included the ones for the sex hormone panel since that's what we're looking at today. But when 5-alpha reductase is upregulated, that could be a sign of inflammation. Aromatase upregulation. So when, testosterone's aromatizing estradiol, her testosterone's on the lower side, her estradiol's on the higher side. When DHAS is lower compared to etiocholanolone and androsterone metabolites, we saw that with her as well. And then when estrogen metabolism is favoring 4-OH and or 16-OH, another sign of inflammation. So she really is kind of ticking each of these signs for inflammation. So that could be another potential cause and driver for this hormonal imbalance and the heavier bleeding. So here's a summary of findings. She has a low normal luteal range progesterone, borderline high estradiol. So kind of looking more like an estrogen dominant picture here. Preference for CYP3A4 pathway with elevated 16-OHE1 and E3. Again, the 16-OHE1 is more estrogenic, adding to that estrogenic load. Elevated 4-OHE1 ratio, normal methylation, which is good, low normal androgens, and then a 5-alpha reductase preference that could really possibly indicate some inflammation going on. So here's our treatment considerations, and really this is not super comprehensive, and it's definitely more of a functional treatment considerations. I didn't go into conventional treatment considerations in this presentation, but these are definitely things to consider based on those Dutch results we just went through. So we do want to do a referral to a gynecologist for exam and imaging. We want to rule out any of those structural mechanical causes for heavy bleeding. We'll run serum labs, those labs that we listed and talked about back on slide 10. And then we really want to support healthy estrogen metabolism, support progesterone production, and then address inflammation. So here are some dietary considerations. Decrease alcohol and caffeine intake. We saw how those can affect that 3A4 pathway. We want to avoid refined carbs and sugar. We want to, an anti-inflammatory diet, and at least eliminating like common inflammatory foods like gluten and cow's dairy. I'm sure a lot of us have seen just removing those two categories can make a big difference for a lot of patients and really decrease inflammation for them. Consider adding spices like turmeric and ginger. They're very anti-inflammatory and can really help with heavy bleeding. We want to increase omega-3 fatty acids and really try to limit those omega-6 fatty acids, which are more pro-inflammatory, especially those arachidonic acid fatty acids that we talked about, mainly coming from animal sources. Those are the ones that really pushing the creation of those inflammatory prostaglandins that can lead to the heavier periods. They also can contribute a lot to painful periods as well. Then we want to increase cruciferous vegetables, choline and trimethylglycine rich foods, other sulfurous foods like onions and garlic. All of these are going to help. Number one, the cruciferous vegetable is going to help favor that protective pathway with phase 1 metabolism. And then the other ones are really going to help with phase 2 detoxification. So we can help move our estrogens out. And then vitamin A rich foods, iron rich foods, really to address any possible, nutrient deficiencies that could also be contributing to the heavier periods. And then buy organic when possible to limit pesticide exposures, because we did see that pesticides can also push that 3A4 pathway. So here are some supplementation considerations. So we really want to support utilizing that green 1A1 pathway. Rosemary extract was on that pathway list to help that pathway. It also can slow the utilization of 3A4, so that's a bonus too. We might consider DIM. Definitely will help us favor the green pathway. Just be a little cautious with DIM because it can lower the parent estrogens, and we don't want to lower her too much. We want to support phase 2 detox of the estriol and 16-OHE1. So that's really with supporting glucuronidation, things like milk thistle or calcium D-glucarate, and then sulfation support, things like NAC, MSM, taurine, molybdenum. We want to support progesterone. We might consider Vitex. Magnesium and B6 are really important for progesterone production. And then we might consider also just supplementing her with progesterone during the luteal phase, at least for a few cycles while we're working on everything else. Anti-inflammatory support that can be really helpful for heavy bleeding is curcumin, fish oil, and ginger. And then if we find that she does have low ferritin levels, we'd want to supplement with iron. And just a couple more, more lifestyle considerations. Stress reduction is always going to be helpful. Finding what works well for a patient that they can incorporate into their lives is really going to be helpful for all kinds of problems. But, stress can definitely lead to hormonal imbalances and contribute to heavier periods. So it's definitely something that we should address. And then increasing physical activity. So highlighted here, found an interesting cohort study that followed Australian women for 15 years. And they found that even though overweight and obese women were more likely to have heavy menstrual bleeding, if they did high levels of physical activity, they were 19% less likely to have heavy menstrual bleeding. So I found that interesting. And high levels of physical activity in this study was about 5 hours of moderate activity, like walking, and this is per week, or 2.5 hours of vigorous activity per week. So nothing extreme, but really good kind of reduction in risk of menstrual bleeding. So I thought that was interesting too. All right, well, we got through this case study. Thank you so much for listening. And if you have any questions, feel free to email us at info@dutchtest.com. Have a great day.